Okay, thanks. So I'm a pediatric neurologist and I'm based at the Evelina Children's Hospital. And unlike the US, we tend to split very early on in terms of whether we see children or whether we see adults. But we work very closely with sort of our adult colleagues. And I just wanted to show you this slide to illustrate two things. One is that in 2011, and some of you sort of might recall, we had a really good meeting. And that's to show, and I remember someone asking me, why do I come to these meetings? And it's because ideas like this are hatched at meetings. And the second thing is to illustrate how long it takes to sort of, have an idea and sort of get it to fruition. But at around that time, and I think this is the same Dr. Frohman that Dr. Sanders mentioned, wrote a monstrous, really great document illustrating the evidence to date of all the clinical and treatment of transverse myelitis, but essentially made our lives easier. So to apply for a grant in this country, usually you're required to sort of do a technical evaluation of the evidence, and it was all there already. So it was at this time that we said, there's three of us there. There was my colleague, Dr. Absood, who was at the meeting, Andrew Jacob, who works very closely with Professor Young from Liverpool, and myself, and inspired by Doug Kerr, who was telling us about very odd things, and it was lingo at that time. Now I suddenly remember, as you mentioned, the slide, and we said, okay, what can we do? We can't match Doug Kerr with all his sort of high-tech stuff, but we could bring the trial a little bit earlier on to when you first had TM, and can we influence it in any way? And some of you will know that, and this is just a sort of background slide in terms of how common it is and how well we do after TM, and we know that outcome is very, very, very unpredictable. And even if it's sort of good, we don't really know which particular patient is going to improve and which isn't. And this is what Michael, my colleague, had sort of reviewed and sort of published a lot of. And at the time, we were also very clear, and it was also a very fast emerging field of this one specific antibody-mediated form of transverse myelitis where you can get inflammation in the eyes as well. And when we were thinking about it, if we were to study TM, there was no way we were able to sort of not look at NMO as well at the same time. And as you know, in the last few years, the science behind this and the sort of biology behind this has also grown significantly. And that's where sort of we thought that we would have to include neuromyelitis optica group of patients, at least if we were to study transverse myelitis. And the treatment at that stage in 2011 was very well outlined in the study. And even at best, as Dr. Sen was saying, most of these treatments are not very targeted anyway, steroids, plasma exchange, and IVIG. We don't really know how they precisely work other than it is an anti-inflammatory agent. And despite that, the best treatment or recommended treatment, it would be steroids. And this is based on class 4 evidence, meaning that it is really a group of experts that have said that it works, and that it is extrapolated from another condition where there is lots of inflammation in the spine, as you see there. And we know sort of from either small randomized controlled trials or sort of anecdotes that plasma exchange definitely or has a benefit. And it's in two contexts. One is in a randomized controlled trial done many years back on a range of patients with inflammation in the brain and in the spine, not just in the spinal zone. And in that paper, there were about 4 patients with transverse myelitis, and if you were very sick and if you were in intensive care and if you had plasma exchange, it had a benefit above standard treatment. That's the trial. And then if you look at a very select cohort of patients, and this is from the Johns Hopkins group, and this is Ben Greenberg that did the study, we knew that of that cohort, if you gave patients plasma exchange in addition to methylpred, the outcome was better. And this is where the sort of literature really was. But in the UK and in a lot of places, plasma exchange is very, very difficult to access, as you know. Was there an alternative? And IVIG is one such treatment. And if you take a group of doctors and if you ask them, and we did this, exactly this, we asked 10 pediatric neurologists, what they would do, and we asked 10 adult neurologists what they would do, it tended to be that the pediatric neurologist said we would certainly try and with IVIG because we used it in sort of allied conditions. I think adult physicians that perhaps do come from a sort of the MS background, where IVIG has really been shown to not change the overall outcome of the patients, would favour not using that at all. At the time as well, there was increasing evidence that in RCTs that IVIG would work in inflammatory conditions, albeit in conditions outside the brain. So these are peripheral, nerve conditions. And there is sort of growing evidence in childhood that it would work in the context of a child with inflammation. But it is not very standardized. It is all in case series and it's all retrospective. And so that's where...
Could I interrupt slightly? I think you should tell people what IVIG
Absolutely,
is.
yeah.
Right. I know you're discussing it in detail.
Yeah.
You haven't even said what it is.
Yes, apologies, yes. So IVIG is pooled immunoglobulins from donors, and like a lot of medicines in that we use, we don't actually know how it works. So it's lots and lots and lots of proteins in you, and some of it are beneficial and some of it are not. And the two real reasons why we think it works in some of the inflammatory conditions is that it induces a breakdown in the proteins in us. Some of them are immunoglobulins, and some of them are the ones that are causing problem. So you induce a breakdown of the nasties. In addition, how immunoglobulins work is that it could also bind to components of your immune system that are humoral, meaning the ones that are produced that actually causing harm to you or causing the sort of immune targeting. So that's globally sort of how it works, and thanks for reminding me that, yes. And that's where we were at with immunoglobulins, and we thought it would be a sort of good idea. And this is what the overview of the sort of evening thought that we had. I think it was a nice dinner, and we said, okay, so do we think that this very odd protein that is pooled from 30 donors, if you add it to standard therapy, which at the time was steroids, could improve our outcome. And we can talk about sort of some of the outcome measures. I'll show you a little bit later. And it's going to be very brief because it's just going to be an overview of the study rather than the details of the study. And I think what we thought at the time was the benefit of this was that we would build a sort of infrastructure of centers that would be able to then spec up to run trials that Dr. DeSena was talking about as they sort of come out, the Lingo trials and the other more sophisticated trials. We just needed the platform to do this, and this was a simpler trial by a long, long, long way, at least so we thought. And building up on that, we'll be able to do trials later on. And again, not understanding a lot of the mechanisms as to how they work, we drafted in some experts in the field, and we'll mention them later. And the benefit of this study is that we will also biobank samples so that we have an idea, or at least a stab at identifying the molecular mechanisms behind some of this. So as I was telling you, after the meeting, Michael and I went and talked to all our pediatric colleagues. Anu talked to all his adult colleagues, and we engaged the help of a clinical trials unit at King's, and reached out to the MS Society, the Guthy Jackson via Anu, and the TM Society, and Lou was involved from very, very, very early on. And then we thought, okay, we had to get people involved as well. Who would be our partners in crime, so to speak? And these are the general centers that we could think of, both in pediatrics and in adults, with adult neurologists and pediatric neurologists with an interest in inflammation. TM, in its own right, is pretty rare, as you know, and I don't think any one of us, even myself, would profess ourselves to be TM experts as such, but we see a range of children. And these are now the sort of 10 to 12 centers across both pediatrics and adults that are involved in this trial. Okay, so what's the purpose of the study? It's to conduct a multi-center study. It's going to be single-blind, because it's not going to be placebo. It's a parallel group. It's randomized. And it's to generate information to see if IVIG is both useful and economical. We had to put the economical in to get the funding, and in adults and children. And the question is simple. It's, does IVIG, given within 5 days of onset of, or within 5 days of starting steroids, beneficial over just steroids alone? Because there's not going to be a trial that we could do looking at steroids. And we would use the 2-point improvement in the Asia scale. A lot of you would be more familiar than this than I was. In fact, I was first introduced to the Asia scale when I came in 2011. And this is done 6 months after randomization. So this is a categorical scale, A to E. Okay, so for there to be a 2-point improvement, you will know that we can only recruit patients from C. Otherwise, there won't be a 2-point improvement. Because it is a scale, at least at the time, that I was so unfamiliar with, we made very sure that all had to be trained and we had to demonstrate a certification before we would be happy that the people could evaluate either children or adults. Then I brought this up mainly to illustrate the point that Caroline sort of brought up a little bit earlier, that the 6 sides of the triangle, the cube, and every aspect is important. And this is actually from her input via Anu that made us think that we have to include lots more beyond the Asia motor scale. And I'll just show you this. So this is the Asia motor scale for those of you who, I think you're going to be more familiar with this because physios and therapists actually perform this more commonly than at least for practicing doctors like myself. But I'm proud to say that I have trained up now and I can do the scores, and I did pass the online testing as well. And these are the other scores of either quality of life or pain scores, and the CSRI is an economic score. It sort of details your contact with your medical profession and input, and somehow it's economically costed. And what we were also very keen on was to look at some of the pain measures and also the bladder and bowel data set, as illustrated by Caroline earlier, to be one of the core, important symptomatology in transverse myelitis. Okay, so 2 minutes, quick walkthrough. We wanted to, or we need to recruit 152 patients, and this is powered by our observations in a pediatric study that about 50% of children have a good outcome as defined by the Asia of C and better. And if we want to improve that to 75%, and to demonstrate that, we need 152 patients. And 10% attrition added to it, and that's why we need 170 patients. So across those 10 to 12 sites, you will see there that all of us will have to recruit at least 15 patients to be able to make this. An average clinical trial usually allows for an attrition of about 30 to 40%. But if you want to do that, you will have to double the length of the trial. So we had to bite the bullet and say we've just got to work twice as hard to get the numbers. And not miss the patients, which is why it's really important that we get every patient. We would recruit them over 2.5 years and follow them up for a year. So the total study will take 3.5 years. This was just to illustrate that. I think Dr. Sam talked about the early outsets of that. You want to make sure that you've got the diagnosis right. You want to make sure it's not something else. So to speed up the process, it can sometimes take a while, we will provide a clinical algorithm that has been agreed by the clinicians. It's not important, it's just to just make the study more systematic. This is hugely based on the criteria that Dr. Senna talked about. And it's not a yes-no, but at least it is an agreed criteria as to what TM is. And we talked about the patients at first presentation of TM where you may not be able to distinguish them from the NMO group. And because of that, we had allowed for patients with TM presenting with the full NMO criteria to be included if it was the first presentation. We talked about the Asia being the categorical score and needing to recruit the score of C and worse. And obviously the duration was what we were interested in how quick is quick. There is no real rationale for choosing 5 days beyond that was pragmatic, and that's what a group of us thought was early treatment. Could have been 6, 7, but we stuck with 5. And these are patients we will not include in the study. You might have seen earlier on as well is that we were very keen to exclude patients that we knew were going to have MS as well. So these are all confounders, i.e., if you want to evaluate the effect of one event, you're not going to choose a condition that's going to have recurrent events, because that would be a clear confounder, except for NMO, where if we controlled for it statistically, we hope to show the effects across both. Plus, we thought it was an important disease as well to include. If you were looking after children, you would know that ADEM is a subgroup of patients with transverse myelitis, and we generally think, at least I don't think we know that, we generally think that the myelopathy outcome or the spinal inflammation outcome in ADEM is a little bit better, so we didn't want it to influence the outcome of the study, and that's why we exclude patients with ADEM, and I think the rest are self-explanatory. This is what you're going to get. So all patients will get intravenous steroids because that's standard, and we made it more standard by saying this is what all our patients will get, and in addition we'll get the IVIG at a dose of 2 per kilo. So this is the standard immunomodulatory dose. Because it's convention for adults to have it over 5 days, we've stuck with that. And because it's tends to be convention for children to have it over 2 days, we've stuck with that as well. Don't forget, this is a pragmatic trial. So this is a trial that the National Institute of Health would want to fund to see that this is common practice that is done out in all the hospitals, so that if we did find an effect, this would be easily sort of translatable to practice within the NHS. Okay, so there's not, it's not rocket science to know that that's not going to work in a lot of patients. So we had to standardize what rescue therapy was in those days. Plex was the only rescue therapy, but as we know now, there are more and more biologicals coming in and being used very early on, even within that time scale that we would have to account for in the study. Steroid weaning is also a potential confounder, and this is what the general group has agreed on that would be a reasonable weaning regimen. And what I haven't touched on is the other downstream aspects of rehabilitation and also the regenerative components that may influence a lot of these outcomes that we talk about. So if my only worry, having listened to Caroline's talk today, is that if you were in Liverpool and your symptoms were significantly better, it's going to be because of the sort of input here, perhaps. So there might be some sort of confounders there, but we hope that it will be balanced out across both groups in a randomized trial. So this is to show you the pathway for a patient. So you would start with getting a diagnosis to see if you're eligible, then you randomize, you get the treatment or no treatment, treatment or no treatment standard, and if you get worse, you get rescue, and you get followed up at 3 time intervals. So this would almost be a near standard follow-up that you would get in a typical NHS setting, except that during the standardized follow-up, you would get much more in terms of evaluation. And this is what it looks like to a doctor, and these are all the things we have to do, and it's just to highlight that these are the most important time point is the 6-month measure. The 3 months and 12 months are what the statisticians made us do to get validation for the scores. And where are we at? So 2011, if you remember, we had the first phase approval in 2012. We had the formal award in 2013. Took us a year to agree the intellectual property with Biotest, so it was going to be a near impossible study to run without the INP, which is the medical product that you're testing, being paid for. Because if you were to use that setting that a trust would approve the medicines, then the current setting, and I'm glad we did it that way, because the current way it works in the UK is that if you need IVIG for an indication that is not approved, you would either have to apply for it individually with an individual funding request, which has more than a 50% chance of it being turned down, at least first time round. So you cannot run an acute trial with that. So Biotest has agreed very kindly to contribute to all the IVIG, and we worked out it's going to be 12 kilos of that. We have opened our first site, which is our site, and we'll be able to recruit the first patient that comes in. We expect to open all the London sites within the month, and our rates are going to be 2 trust stroke sites per month, so we hope to open all sites by August 2015. And this is just a thank you to all the collaborators. Barbara and Lou sits on our trial steering committee. We have a great drug monitoring committee, and you can have a look at some of the summaries of the protocols and things on the NIHL website. And importantly is to thank all the PIs, and Saiju, I'm not sure, is he here, Dr. Jacob? He from Birmingham is part of the team here as well, and this would be the key context, and I'm very happy to take any questions about that. Rosemary, who's our trials manager, will be very able to provide lots of information on the trial, and I know that we've just done one for Barbara on the TM Society site, but I wasn't sure whether it's on it yet or not.
Not on it yet, but it will be soon.
Yeah, soon. And that's it. Thank you.